This video will cover malabsorptive and osmotic diarrheas. Infectious diarrheas will be covered in a separate video. To start, we'll give a general overview of the different types of diarrhea. Diarrhea can be divided into secretory, osmotic, malabsorptive, or exudative. In secretory diarrhea, the stool is isotonic and the diarrhea will persist during fasting. In contrast, in osmotic diarrhea, the stool is more than 50 milliosmolars more concentrated than plasma and will improve with fasting. Malabsorptive diarrhea results when there is inadequate nutrient absorption due to mucosal damage, and it is associated with diarrhea or fat in the stool. This type of diarrhea is also relieved by fasting. Exudative diarrhea is found in inflammatory disease, in other words, IBD, and is characterized by the presence of stool leukocytes. It can also be a part of the process of infectious gastroenteritis. This will persist with fasting. Again, malabsorptive diarrhea results from defective absorption of fats, fat and water-soluble vitamins, proteins, carbs, electrolytes, minerals, and water. It presents as a chronic diarrhea with fatty stools, weight loss, anorexia, abdominal distension, and muscle wasting. Etiologies include pancreatic insufficiency, celiac disease, Crohn's disease, graft versus host disease, environmental enteropathy, and CF. We will go over each of these. However, Crohn's will be presented in a different video. The defective absorption can be the result of a problem at one of 4 steps in digestion. 1. Intraluminal digestion, which involves the initial breakdown of proteins, carbs, and fats into absorbable forms. 2. Hydrolysis of carbs and peptides by the disaccharidases and peptidases. 3. A problem of transepithelial transport. Or 4. A problem with lymphatic transport of the absorbed lipids. So we'll start with CF, cystic fibrosis. One clinical feature of cystic fibrosis is malabsorptive diarrhea. The absent CFTR leads to defects in intestinal and pancreatic ductyl chloride ion secretion. In the intestine, this interferes with bicarb, sodium, and water secretion and results in failure of hydration of the luminal contents. As such, newborns with CF will have meconium ileus, or a delay in the first stool. In the pancreas, the thick secretions will obstruct the movement of digestive enzymes into the duodenum. The enzymes become activated in the pancreas and will begin to digest it. Eventually, pancreatic insufficiency from autodigestion occurs. This leads to difficulty absorbing nutrients as the enzymes that are normally involved in the breakdown are no longer available. This can be partially managed by oral enzyme supplementation. Celiac disease or celiac sprue, or as it's also known, gluten-sensitive enteropathy, is an immune-mediated enteropathy triggered by gluten. Gluten is digested by enzymes into amino acids and peptides, including gliadin. Gliadin is then deaminated by tissue transglutaminase, or TTG. The deaminated gliadin is then presented by antigen-presenting cells via MHC2 to the CD4 positive T cells. These is associated with the haplotype HLA, DQ2, and 8. It is the T helper cells that mediate the tissue damage. You also get a B cell response, though, in which anti-tissue transglutaminase, anti-deaminated gliadin, and anti-endomeseal antibodies are produced. The CD8 positive T cells may also play an ancillary role in tissue damage via cytotoxic action, killing the enterocytes. Eventually, you get loss of mucosal and brush border surface area, which leads to malabsorption. Children with celiacs classically present at 6 to 24 months with abdominal distension, diarrhea, and failure to thrive. Kids with non-classical symptoms can present at an older age with just ab pain, nausea, vomiting, bloating, or constipation. In adults, celiacs typically manifest between 30 to 60 years of age. Some patients can have silent disease in which they have a positive serology and villus atrophy on biopsy, but no actual symptoms. Those with latent disease have a positive serology, but no villus atrophy. Symptomatic adults often have chronic diarrhea, bloating, and iron deficiency anemia. Dermatitis herpetiformis is a characteristic clinical feature which involves pruritic blistering skin lesions, and it results from IgA deposition in the skin. Another clinical feature is that symptoms will resolve with a gluten-free diet. In terms of diagnosis, serological tests include testing for the presence of IgA antibody to endomysium. These are specific. You can also test for the TTG antibodies or anti-gliadin antibodies, and these are both sensitive tests. IgG antibodies can also be present. So on biopsy, you will see flattening of the small intestinal villi, crypt hyperplasia, increased intraepithelial lymphocytes, and this damage is going to be greatest in the duodenum. In A, you can see normal small intestinal mucosa, and in B, you can see the blunted villi. So celiac is managed by a gluten-free diet. It is associated with an increased rate of malignancy, especially enteropathy-associated T-cell lymphoma. Small bowel adenocarcinoma is also more common in those with celiacs, and as such, cancer should be suspected when patients become symptomatic despite a strict gluten-free diet. The next one we'll talk about is environmental enteropathy. This was previously known as tropical sprue, and that is because the damages to the small bowel villi was thought to be due to an unknown organism, and it occurred more often in tropical or developing regions. We don't know exactly what causes it, but one hypothesis is that recurrent post-infectious diarrhea leads to a cycle of mucosal injury, malnutrition, infection, and inflammation. The damage is going to be more prominent in the jejunum and ileum. Patients can have B12 or folate deficiency, resulting in anemia, in addition to the diarrhea. In this case, the supplementary feeding, vitamin supplementation, or mineral supplements won't fully reverse it. Biopsies do appear similar to celiacs with blunting of the villi. So Tropherium whippleyi, or T. whipplei, is the causative bacteria of Whipple's disease, in which macrophages become full of the bacteria and compress the lacteals. As a result, chylomicrons can't be transferred into the lymphatics from the enterocytes. This results in fat malabsorption and steatorrhea. The small bowel is most commonly involved, and on histologic exam, you can see blunted villi and foamy PAS-positive macrophages. Patients are going to present with steatorrhea, fever, rarely endocarditis. You can also have polyarthritis, neurosymptoms, skin pigmentation, and lymphadenopathy. A good way to remember this one is foamy whipped cream in a can, where foamy refers to your foamy PAS-positive macrophages, and C is for cardiac, A is for arthralgias, and N is for the neurological symptoms. And in this picture, we're just exemplifying some of your foamy macrophages. So A-beta lipoproteinemia is an autosomal recessive disorder characterized by an inability to export lipoproteins and free fatty acids. If we go back to our physiology, we can remember that in the lumen, fat globules are first broken up into smaller emulsion droplets by bile salts. The lipase then digests the fats into emulsion droplets to form monoglycerides and free bile acids. These are packaged into micelles, which are taken up by the enterocytes. The monoglycerides and free fatty acids are synthesized into triglycerides in the ER and then coated with lipoproteins to form chylomicrons, which are then exported into the lacteals and lymphatic system. However, in A-beta lipoproteinemia, there's a mutation in the microsomal TG transfer proteins, and B48 and B100 B48 is required for chylomicron formation, whereas B100 is required for LDL formation. Since enterocytes are now unable to export the lipoproteins and free fatty acids, the monoglycerides and triglycerides will accumulate within the enterocytes. This manifests as failure to thrive in infancy, as well as diarrhea and steatorrhea. Patients also have deficiencies of fat-soluble vitamins and acanthotic red blood cells, also known as spur cells, due to lipid defects in the plasma membrane. So on biopsy and histologic exam, you can see enterocytes filled with lipid vacuoles. The oil red O stain will highlight these vacuoles. The bottom right side is just a picture of an acanthotic red blood cell, which can be seen on peripheral blood smear. This is just one of many disorders that can cause spur cells. The next disorder we can talk about is IBS, which is most often seen in 20 to 40-year-old females. It is thought to result from a combination of psychological stressors, diet, and abnormal GI motility. Patients will have chronic and relapsing ab pain, bloating, diarrhea, and/or constipation. Despite these symptoms, no gross or microscopic changes in the bowel are seen, and this remains a diagnosis of exclusion. So microscopic colitis encompasses both collagenous colitis and lymphocytic colitis. Microscopic colitis is an idiopathic disorder characterized by chronic, non-bloody, watery diarrhea and weight loss. Collagenous colitis typically affects middle-aged to older women, and on biopsy, the histological exam shows a thickened subepithelial collagen layer with increased intraepithelial lymphocytes. Lymphocytic colitis, on the other hand, will show markedly increased intraepithelial lymphocytes. So this means there's like up to 120 of them within the field. The subepithelial layer is normal in size, however. Lymphocytic colitis is associated with celiacs and other autoimmune diseases. For microscopic colitis, just think of an older woman with non-bloody chronic diarrhea. Diarrhea secondary to graft versus host disease typically occurs after allogenic hematopoietic stem cell transplantation, where the donor T cells target antigens on the recipient's epithelial cells in both the small bowel and colon. On histology, you can see apoptosis of the crypt cells. Clinically, these patients will just present with watery diarrhea status post-stem cell transplant. Okay, so now we're going to switch gears and talk about osmotic diarrhea. Osmotic diarrhea results when there is an osmotically active, unabsorbable substance present in the stool. Characteristically, the stool will be more than 50 osmolar concentrated than the plasma and will improve with fasting. So the disorder most commonly associated with osmotic diarrhea that you probably already know about is lactose intolerance. Normally, the brush border enzyme lactase breaks down lactose into glucose and galactose, which are then absorbed by the enterocytes. Lactose is an osmotically active substance and will remain in the lumen, drawing water into the intestinal lumen. This will result in explosive diarrhea after ingestion of milk and other products containing lactose. The diarrhea will improve when these food products are removed from the diet. So it is either congenital or acquired deficiency. In the case of congenital deficiency, it is due to an autosomal recessive mutation in the lactase gene. Acquired deficiency results from downregulation of gene expression, and this is believed to convey an evolutionary advantage for those populations that stop consuming milk in their diet at a young age. As such, the acquired deficiency is more common in Native Americans, African Americans, and the Chinese. Acquired deficiency can also occur transiently after a small bowel infection. So that concludes this section.